What we wanted to do next, though, was kind of talk about this portion that we do every month now. It's kind of our model spotlight of, we call it This Is How We Do It. And it's kind of giving like a little 5-minute overview of one of our team members here and how they do integrated care, or how they address some of these things at their clinic. And so Michelle was nice enough to volunteer to lead us. She's from the University of Rochester Medical Center, and if it's okay, I'll just turn it over to you, and I'm really excited to learn how you do things there.
Sure. Okay, I'm going to share my screen. Okay. Oh, I started you at the end. Okay, so I have 5 minutes, so I'm going to try to tell you in 5 minutes what we do here in pediatric rheumatology. The goal of the spotlight is to review different integrated care models, and we haven't done a specialty care model yet, so I was excited to do this. All of my clinical time actually as an integrated pediatric psychologist is in specialty care in pediatric rheumatology. So I'm going to tell you a little bit about what my time looks like and what we do. And I think it'll connect nicely to our conversation about pediatric pain, since pain is my life several days a week. So this is us. This is the University of Rochester Medical Center. We have a new children's hospital over there on the left, and pediatric rheumatology is there for inpatient and outpatient care. Right now, all of my time is with outpatient care. And then on the right there, you'll see one of our outpatient sites, and rheumatology has a clinic there. I tried to find a good picture with lots of snow, since that's what people think about when they think about Rochester, but couldn't find a good one. But this is a reminder, this slide is a reminder of what specialty care is and how it's different than primary care. And as you can see here, specialty care, our work really is focused on a lot of consultation and on managing more chronic, complex medical needs. So it's different than primary care in that way. But of course, we're having to do a lot of collaboration with primary care, because that's where the medical home is. So we do quite a bit of that. But it does seem like that affects our work as psychologists. In case you don't know much about pediatric rheumatology, here are the conditions that we see. As far as I can tell, there aren't many psychologists integrated into rheumatology. So if people know others, I would love to meet them. I think that I've only met one so far. But this is what we see: arthritis, lupus, autoimmune conditions, immunodeficiency disorders, and musculoskeletal disorders. And with all of these, there's some level of pain that is brought up in some course of the illness. And a big role of mine is actually working with our patients with amplified musculoskeletal pain syndrome. And we see about 450 patients in a pretty large geographical area of Western and Central New York. So for those of you who are not New Yorkers, which is, I think, most everybody, that's anything west of Albany. It's a pretty big area with some cities and a lot of rural areas. So as far as what I do, I thought I would highlight this part that we don't talk much about, but is really an important piece of the work that we do, which is this indirect consultation that we do with our medical teams. I think some of the things that I enjoy the most as a pediatric psychologist is sitting with the team, reviewing families and patients, and being able to say things like, and how is their mental health? Or how is their stress level? How's the family doing with that? And asking questions that help the medical team really think about the psychosocial pieces that might be playing a role. And then another role of mine indirectly would, and probably all of us, is when we're sitting with a team, something I try to always remember is to bring the family and patient's voice to those team meetings. So I think that's an important role that we have, where I'm constantly asking about the family. But the team now, after it's been about 10 years, they will now ask me, I have this sensitive topic, Michelle, how do I talk to this family about this? Do you have some ideas? And we'll think together about how to do that. That's some of the work that I love. That's the indirect consultation with the team. And then the direct care is very similar to what we've reviewed with primary care. The the one-time consults where you'll pulled in for an appointment. In rheumatology, it's usually on pain management, coping with a new diagnosis, or maybe some behavioral symptoms that are coming up, mostly because you're talking about a needle coming in the room soon. So, so that's what the consults are usually about. There's meet and greets, and then I do have some ongoing mental health appointments that'll more of that brief treatment model. And in rheumatology, I think what's different is it tends to be focused on getting this diagnosis, which really is going to change a family's life for a long time. And the other thing that the focus of the mental health appointments is on is pain management, and then health anxiety and needle phobia. And then one of my big roles that is separate than clinic is running our outpatient amplified musculoskeletal pain clinic. So I kind of have two roles. I have the clinics, and then I have the pain clinic. And these are, again, the things that I tend to see the most. I think I've reviewed most of them. Pain management, needle phobia, mind-body connection. Those are the big themes for pediatric rheumatology work. As far as my time, I have 2 outpatient clinics, and so I'm in the same location using the same rooms as the rest of the medical team. And on Fridays, something that I really pushed for was to be there during the training clinic. So pediatric rheumatology has a rheumatology fellow that is there on Fridays. And so I asked to be there, and it's really allowed a lot of great training opportunities with him and I collaborating on patients together. And I ended up really advocating for me to be part of other things like journal club and case reviews. And it's, I think, really helped our team be more psychosocially minded. And then we have our AMPS evaluation clinic, which I run, and then I run the 6-week treatment program for AMPS. So happy to talk more about those since the theme is pain, but I'm sure that'll come up later. I think I'm at my 5 minutes, so I'll just let you know what our questions are. The main things that we're asking about, much like all of you, is how do we best evaluate outcomes? How do we know what we're doing is working? And are families satisfied with this? Are families noticing the benefits of the integrated care? The other thing that I think all of us struggle with probably is how do we assess the needs of our patients coming in and decide, do they just need a one-time consult? Do they need brief treatment? Or do I need to refer out for mental health treatment? Which I don't know about all of you, but that can be really difficult for me once I've had this relationship with patients, especially in rheumatology when they have a chronic illness or chronic pain. What happens is we have this conversation about, well, you work with my medical team, you understand medical illnesses. If I go out in the community and see a general therapist, I don't know that they're going to understand in the same way. So that comes up for me a lot, and I struggle with referring those patients out or not. And then we've been trying to consider starting a group treatment model for pain. So that's something I'm interested in learning more about, whether to do that on the medical side and have like a medical group appointment, or whether to do that in more of a group therapy or group education curriculum type model. And we're always looking to find more ways to have psychologists, especially, doing more training. So we're trying to figure out ways to do that. So phew, that was fast. Yeah. Would it be I don't know. What do you think, Matt? Should we talk about anything, or do you want to move?
Yeah, thank you so much for presenting that, and you know, kind of leading us through how in your specialty model you're still integrating. And I think I really like how you were talking about even that indirect consultation and how that can be a, you know, real added value added service for the whole team, you know, even if you're not directly meeting with the patient in particular. But I thought maybe we could just take a second. If folks have questions or comments for Michelle too, feel free to ask. I think one comment in the chat was, what is AMPS?
Yeah, I said what it was and then I kept going really fast. So AMS is amplified musculoskeletal pain syndrome. That's the umbrella terms for things like CRPS. The old terms were RND and RSD, if you've heard those terms. We don't use, at least in Rochester, our theory we don't diagnose juvenile fibromyalgia, and this is quite similar to that, but we tend to avoid that diagnosis because of the length of time people connect to the term fibromyalgia. And great idea about the ACT group for chronic pain. Thanks, Marla.
Other questions or comments other folks had?
Hey, Michelle, sorry, I joined a little bit later. I'm wondering about the monthly multidisciplinary clinic that you do, because I work in a primary care clinic, but it also has like a monthly neuromuscular assessment clinic, and we're thinking about how to manage autism in primary care. And I'm just curious how you balance those different hats that you're wearing in your clinic, and sort of how that gets structured and stuff.
Yeah, this always happens when I present. I don't know if all of you have this, but you present your work and they're like, wow, there's a lot of different hats here. So we specifically, what was happening is we were referring people to our outpatient pain program. And what happened was we were getting a lot of inappropriate referrals or referrals that didn't need our level of care. And so we chose to create this evaluation clinic to help do a more interdisciplinary, thorough evaluation of the kids and then make a pain plan for each of them, with some of them going on to being part of the pain program and some not needing it. And so the way that we structured that was we have 4 of us. We have a nurse practitioner from rheumatology, myself, an OT, and a PT. And we split up into pairs and do our own evaluation. So I do an evaluation with OT, as you can imagine, mostly about functioning. And then PT and the nurse practitioner do an evaluation. And then we all come together, review our thoughts, and then go back with treatment recommendations for them. I'm trying to think about how to do that in primary care, but I do think there is a role for primary care to be paying more attention to chronic pain. And maybe a prevention role, really catching these kids a lot earlier.
Yeah, we have specialists come to our clinic once a month and do a similar, like OT, PT, speech will come here. We'll also get pediatric surgery. Sometimes we have Pete's GI come, a variety of different specialists will rotate through this primary care clinic. So it's really a unique setting. Yeah. And so I'm always sort of like, I'm here for warm handoffs as they come up with anybody. And I've sort of left it at that because I'm also trying to manage so many other things in the clinic, rather than assert myself directly into that group. But there are times when they do pull me in, especially if there's other family related things or, questions about siblings, right? And how they're managing what's happening in their life versus their sib. So yeah, I definitely think there is a role for us, and sometimes it's just hard to balance. Yeah, because Pete Psych gives us so many awesome skills in a variety of different areas.
Yeah, and there's so many roles in acute pain and with chronic pain. Yeah, so that really.
Oh yeah, and then our department chair is also a cardiologist, so he gets POTS patients coming through primary care, and so doing warm handoffs with them, and so I do feel like I'm having to figure out how to balance all of it. For exactly that question about like, when do we keep them here? When do we refer? I think that's always been something that we balance in primary care.
Yeah. Well, Michelle, thank you so much. And we definitely want you to kind of help with your expertise, lead this facilitated discussion here in a minute too, that's going to expand more around chronic pain. And if anybody else wants to be a rock star presenter like Michelle and give their 5-minute spiel about what they do, we're always looking for people to present. So feel free to, to email me or Allie or Cody, and we'd be happy to have you present at one of our future months.